Our next session is going to be, a lawyer and a doctor, Dr. Michael Painter, Senior Program Officer at Robert Wood Johnson Foundation. He's a distinguished physician, attorney, healthcare policy advocate, and 2003-2004 Robert Wood Johnson Health Policy Fellow. He's a Senior Program Officer and Senior Member of the Robert Wood Johnson Foundation Quality and Equality Team. Painter sees the team with its mission to help communities improve the quality of health care for their citizens as benefiting from Robert Wood Johnson Foundation's unique vantage point, leverage, and credibility in health and healthcare. In 2003-2004, Painter was a Robert Wood Johnson Foundation Health Policy Fellow with the Office of Senator William H. Frist, MD, former Majority Leader. He describes his role as an extraordinary opportunity to employ both his medical and legal expertise in helping to formulate healthcare policy at the national level. Prior to that, he was the Chief of Medical Staff at the Seattle Indian Health Board, a community health center serving urban American Indians and Alaska Natives. Painter led the clinic's award-winning diabetes team. He has a clinical faculty appointment with the University of Washington, Department of Family Medicine. He is a member of the Cherokee Nation of Oklahoma, American Academy of Family Physicians, Association of American Indian Physicians, National Medical Association, California Bar Association. Painter earned a JD from Stanford Law School and an MD from the University of Washington. He received his residency training at the Providence Family Medicine Residency in Seattle and is board-certified family physician. He earned a BA in economics and mathematics from Vanderbilt University. Dr. Painter.
Ain't gonna go blind.
Morning, everybody. How you doing out there? Great. Good. Thanks for that introduction, and thanks so much for having me here today. This is my first visit to Atlantic City. Before this, my experience with Atlantic City was on Boardwalk Empire, which I love, so I'm really thrilled to be here today. I guess you guys are as well. As Dave mentioned in the introduction, I'm a Senior Program Officer at the Robert Wood Johnson Foundation. I'm a family physician and an attorney, and I spend most of my time working on quality, cost, and value issues. I'm going to today talk to you a lot about what the Robert Wood Johnson Foundation is doing, but I'm going to start my comments, sort of frame them in terms of an epic story, if you will, and I'm going to borrow the Star Wars genre a little bit to do that, and take us through that story. Then I'm going to pause just a little bit and talk about how, this is obviously a topic near and dear to your guys' heart, but talk about how technology integrates into our individual lives and how it helps all of us as individuals approach our health decisions and our health care decisions. And then I'm going to turn and walk you through a lot of the activities that the Robert Wood Johnson Foundation is doing these days to help improve health and health care. And then I'm going to end with some of our next step frontier kind of thinking. So hold on to your hats a little bit. This slide is a snapshot of a blog post that appeared in the healthcare blog. And I wrote it as reflecting on my participation at the Health Data Initiative meeting in June this last summer. And I sort of framed it again with this Star Wars motif. And I thought I would build on that today for our discussion. So I'm just going to pretend you don't have to pretend you're in a theater because you are, but pretend we're watching the Star Wars opening, a version of the Star Wars opening crawl. A long time ago, in a galaxy far, far away, it is a period of enormous change and worry. The challenges are great. The status quo of poor health care quality and crushingly high costs is bearing down on the people. But that enemy is also under attack. A growing band of folk from all parts of the galaxy are attempting to bring every imaginable force, technology, market, government, people power to the cause. No one's certain how it will all turn out. And then in my blog post, I sort of cue the Darth Vader theme, and we could have done that, I guess, today. And that's because we're up against some big challenges that we all know here. We're talking about the Darth Vader theme here a little bit, but I do want to pause and talk about that Darth Vader boogeyman isn't necessarily what we all might think of as our boogeyman. What I mean here is the status quo, the myriad forces for dysfunction that have year after year after year piled on to get us to this point. And those problems are mounting, of course, and they're mounting in such a way that what many of us have known in discussions when I was Dave mentioned in my introduction that I was a health policy fellow in Senator Frist's office and the Majority Leader's office. That was in 2003, 2004, and folks knew then that this cost and quality problem was going to come out of the sort of the boutique healthcare discussions and become front and center of our nation's problems. And like a bad movie, here we are with all these headlines. So I don't think it's too much to say, too much hyperbole to say that the solution to these costs and quality problems are incredibly important, and they really impact our national destiny itself. So the question is, will we or won't we get a handle on those problems? In my imagined Star Wars scenario, in my epic story, I ended that post on a hopeful upbeat. It's sort of the Return of the Jedi moment where we all together, working together in a ragtag kind of concerted way, eventually defeat the Death Star and the Empire, and everything's great. But that happy scenario is very premature for us, unfortunately. But I'm getting a little bit ahead of myself. Let's back up here. So again, I work at the Robert Wood Johnson Foundation. We're just up the road about an hour and a half in Princeton, New Jersey. I drove down this morning. We are the nation's largest foundation devoted to improving health and health care, and we attack these problems in a variety of ways. I mentioned that I work on quality, cost, and value problems, and there's a team of us that have a portfolio that do that. We target childhood obesity problems, public health, coverage. We also have a portfolio of investments that are working on cutting-edge pioneering efforts and things like that, and I'm going to touch on some of those today. I did want to direct your attention to one part of this slide, which is that live, learn, work, and play point, which is, we think it's really important, and this has been an evolution in our thinking over the last many years, but the place matters. Place matters in terms of how we improve our health and how we improve health care, and we've really tried to design our interventions and our projects and our efforts with that in mind. And I'm going to take off on that a little bit, and I am going to use I beg your forgiveness, but I'm going to use myself a bit as an avatar here to walk through some of the individual aspects of that and how technology plays in that. And then, like I said, we'll go to the Robert Wood Johnson Foundation healthcare stuff. So I mentioned I live in New Jersey. But I also live and learn on social media a lot these days, and so this is one other way to introduce myself. I'm at PaintMD on Twitter, so if you don't follow me, please do. But we talk a lot about the things that we care about and the quality, cost, and value agenda, and things we do at the Robert Wood Johnson Foundation all over the country, so please follow me there. But we at the foundation are thinking a lot about how to leverage social media into the things we do and the change we're trying to invoke. So that's really important. But I also like to play. I'm sure you guys do as well. And who knew? I actually went to school out on the West Coast and lived for many years in Seattle. And the reason I migrated over here to the East Coast is because of my passion about helping us solve some of these complicated and complex problems. But I do like to play, and New Jersey and Pennsylvania and New York are terrific places for those who love cycling like I do to do that. And these are snapshots of me earlier in the spring and summer on a Grand Fonda, New York ride, and climbing Whiteface Mountain up at Lake Placid. My point, though, isn't just to talk about that, but it's also to show how integrated and how just obvious it is that we use technology both the hardware and playing to measure my heart rate and my positioning, and also to immediately share it to we're using a variety of kinds of software applications for my own recording, but also with my friends and colleagues and people I'm competing against. So it's absolutely real, and as you know, it doesn't take much of a leap to sort of think about, well, what are the sort of the more sort of exploded out health and healthcare applications of that, and we're thinking a lot about that at the Robert Wood Johnson Foundation. We're also thinking about personal health records, and again, just sort of playing on this play point a little bit. Personal health records have had a varying track record. I'm going to talk a little bit about one of our programs that's trying to sort of understand how we can best use personal health computing to advance health and healthcare improvement. But here is an example of something that's really important to me, and it's essentially, I have a number of personal health records, but this is one I use probably the most, and I wear it all the time. It's my road ID. I go out on my cycling adventures with my teams and by myself, and I count on, if something happens to me, that the emergency responders can look at my low-tech bracelet, find the serial number, and go to my personal health record, which I've given them permission by my bracelet, and see all of my relevant medical information and my contact and my doctor and everything. I want them to have it, and by the way, it has a unique identifier specific to me, which I think is interesting. I do, unfortunately, have other personal health records. I used to have a Google Health record, and I've seamlessly moved that over now to Microsoft Health Vault, and I connect with my doctor's office through his electronic health record, and I have a patient portal there. I guess my point here is I have too many personal health records, and it would be really great if I was able to put them all, and I want it, and I need it, and that road ID point is a value proposition for me in personal health computing that we're really anxious to see that sort of coalesce into something that's even more valuable. But I do work, and since I arrived at the foundation back in 2005, I almost immediately started working on a place-based strategy to help improve health and health care. And this went through a number of years of transition and ultimately has become the centerpiece of the Robert Wood Johnson Foundation's effort to improve quality, cost, and value across the country. The name of the program is Aligning Forces for Quality. I don't know if any of you have heard of it. This is a map of the communities that we're targeting. 16 communities across the country, 4 of them are states, a number of them are metropolitan areas or multi-county areas, and we've been working with these communities, these healthcare markets, since 2006, and we've made a commitment to work with the communities that have ongoing success on through 2015. There are a number of programs and initiatives that have followed along behind us, emulating the work we've done, like the Beacon Community Program, which you're probably familiar with, or ARC's Chartered Value Exchanges, all sort of based on this same premise about a place-based strategy, working with leaders in a healthcare market and going place by place to change and improve healthcare there, rather than trying to do it centrally and nationally. We know that that doesn't necessarily work so well. I am making an assumption here. I guess I should say that we're all on the same page about, man, we have a huge national healthcare cost problem and quality problems. And obviously the way when we think about quality problems, you can sort of parse it in the sort of the Institute of Medicine angles of quality, but also you could think about it as overuse. It's bad quality if you're having wasteful health care and using too much health care. There's misuse, there's just unsafe care, of the wrong care at the wrong time. And there's underuse, of course, when people don't get the care they need, that if they did get it, we would have better outcomes. And so it's sort of being penny wise but pound foolish in those situations. So that's kind of how, on the quality aim, that's how we're sort of thinking about it and trying to help these communities adjust to that. But also in the context of thinking about cost and then the overall value equation as well. So again, Aligning Forces is for quality. This initiative is well over $300 million, sustained 10-year effort to help these communities do this work. It is the centerpiece of the Robert Wood Johnson Foundation's effort to help improve quality. I wanted to point to that boxed statement, and that sort of gives you a sense. When I first showed the Robert Wood Johnson Foundation slide, I mentioned there were all these investment teams basically, and I'm on the quality/equality team. And our targeted goal here is to help these regions improve and sustain healthcare quality and patient-centered, equitable care by 2015. That's what we spend all of our time, all of our investments, and we're accountable to our trustees and our senior management and the public for making advances in that. I'm going to talk a little bit more about what those advances are. But I wanted to pause a little bit and talk about the theory here. So is it just working with communities and doing some improvement and throwing in some technology and hoping for the best? It really is not. When we designed this back in 2005, we were looking at the extreme dysfunction in these healthcare markets across the country. We worked with a variety of experts and essentially conducted a scan across the United States of specific communities and looked at what was going on or not happening in these communities and really parsed it into things like, well, what's happening with the available information for people to have when if they were trying to work in a functioning healthcare market, so measurement and public reporting assets. What's happening with engaging the consumers? What's happening with payment reform? What's happening with health information technology? What kind of improvement resources are these communities able to provide health professionals once they start to realize that they have quality deficits and they actually need to improve? And as it turned out, back in 2005, when we did that initial sort of, well, what's going on out there, it was really bad, mediocre across the country, and not surprisingly so, given the level of dysfunction. We gave them letter grades. Everybody almost got a C for varying reasons. But when we rolled up the score, they all got Cs. One community got a D, and one community got a sort of a B minus. But what that did, by parsing that huge, complicated problem in that way, it gave us areas of focus, which is how we started this program, into a three-ring set of activities and targeting these communities, working with multi-stakeholder leadership alliances in each of those communities, and then having them work in a set of activities on advancing rapidly their ability to measure quality and cost, and then publicly report, make that very transparent to the marketplace. Begin a set of activities to help engage the public with the information. And then, importantly, looking to the health professionals, you can't just leave them out there once they start getting all these signals to improve, but help provide resources to them to actually improve once they receive those kinds of signals. Wrapped all around that, we have this equity notion, which means when you are sort of looking at these complex problems and trying to sort of take a hard-nosed kind of cost and quality marketplace attack on that, if you aren't paying attention to the vulnerable, to the racial and ethnic and language disparities, you're likely to make them worse. At the same time, doing all this kind of concerted targeted activity gives us a tremendous opportunity to actually close those kinds of disparities and gaps. So that's really important to the work we do and an important part of this initiative. I mentioned that each of the 16 communities works through a leadership alliance, and I'm just using Detroit, which is one of the Aligning Forces communities, and this just gives you a sense of the alliances include the health professionals, the main health professionals in a market. They include consumers and consumer advocacy organizations, both on an individual basis, setting on these alliances, as well as the consumers themselves. It includes health plans, all the relevant health plans in a marketplace, and the major employers. So all of those working together have agreed to come to a table, sort of lay down arms, and work on those set of concentric activities to make progress for their communities. And they are, and I want to brag about that just a little bit. So when I mentioned that one of the important points was, well, there isn't any information that's widely available about the quality and cost of care for these folks in these communities, so to speak, for the folks in these communities to actually improve once they start to want to improve. So most of the communities had to start from scratch. A few of them, like Minnesota, had actually been doing some work in measurement and reporting. I have the Minnesota slide up here. This is a screenshot of their website. This is a static website where folks, anyone can go and click through and see what's going on with hospital quality, what's going on with medical group quality. There's some cost information up there. The point is that when we started, only a handful, Minnesota and a couple others, had very rudimentary information up there presented in a not very helpful, usable way. And now, flash forward a few years, all of them do. And so that was a major leap forward in terms of where those marketplaces were and where the field is now, as we've sort of drug a lot of people along in this effort as well, we think. I realize this is sort of a boring slide, but I mentioned accountability that we have. So we're accountable to the public and to our Board of Trustees for making progress in this work. And so we have a variety of very granular indicators about where communities were and what they're doing with our money and our technical assistance that we're providing through this effort. And we roll those scores up into those areas of measurement and public reporting and quality improvement and consumer engagement. And this is just a snapshot of where the 16 were back in 2007. You get a red dot if you have not really succeeded at all in the rolled up score. You get a yellow if you're partway there, and you get a green if you're good to go. Flash forward 4 years, and almost all of the communities have completed almost all of the work that we set out for them to do back in 2007. A couple came on later, and one is having just a little bit of difficulty, but other than that, you see how the board is really lighted up. So that is an indication of the kind of, and it is sort of process a success we're having. I can't show you quite yet, but I'm going to talk a little bit about the kinds of quality improvement, the outcome stuff that we're seeing. But this is the building, kind of the infrastructure coming up out of the foundation as these communities are really restructuring their marketplaces as they're going based on this collaborative alliance work. I mentioned success, and a number of you may have seen this recent article in the New England Journal. This is from one of our sites, the Cleveland site, and it's interesting because Cleveland has a fairly widespread adoption of the electronic health record, and the team there did a study comparing providers, safety net providers that have an electronic health record and the quality metrics that they report in the Aligning Forces program compared to safety net providers in that program that are still on a paper-based record. And they tried to control for a variety of factors, and they did. We don't want to read too much into this because it is in this sort of rarefied, unusual setting of this focused attention in this community with Aligning Forces and other efforts. But the headline is that they had the safety net providers that were using electronic health records had dramatically improved quality compared to those that were still using paper-based records. So that's sort of a peek into the future of what we hope to see. I should say that, again, I think you're getting the notion that in this complex problem that we're trying to help everybody target, there are no silver bullets, obviously. We don't think electronic health records or technology or anything like that is. We don't think measurement and public reporting is. We don't think engaging a bunch of consumers to demand it is either. But we think that all of that together, working in concert, can change the sort of complex adaptive system problems that we have in healthcare. And so this is just an example of putting in a setting where there's a lot of HIT adoption, electronic health record adoption, where there is some success that seems to be happening. While we're talking about electronic health records, I did want to note that I mentioned in our scan, we looked at what's happening in health information technology way at the very beginning of this effort, and most of the communities didn't score very well at all. It was really bad, and we made a strategic decision that even as big as the Robert Wood Johnson Foundation is, we had no way of driving adoption of electronic health records. And so we knew that those kinds of technology tools obviously are really important, but we wanted to work on other kinds of infrastructure, help the communities work on other kinds of infrastructure issues while we were waiting for the technology adoption to happen. That doesn't mean we weren't paying attention. And I just put this slide up because since 2006, we've been working in collaboration with the Office of the National Coordinator, started with Dr. Brayler and segued with Dr. Blumenthal's tenure on a gold standard report on what's happening with the state of adoption and meaningful use of electronic health records and health information technology in the United States. We started this report, I said, in 2006, and we've been reporting them cyclically since then. Dr. Blumenthal, David Blumenthal, was the initial grantee for that work, and then he transitioned to himself become the national coordinator, and his team at Harvard continued on. This is a picture of the 2010 report. We have the 2012 report will be coming out with the 2011 information in it, so watch for that. More examples of success, and this is, I wanted to go back up to Minnesota and Wisconsin. This clinic is a rural-ish clinic in Wisconsin, but because they're neighbors up there and whatever, they actually post their public reports on the Minnesota Community Measurement report. And this clinic of dedicated professionals learned in their 2009 report that only 47% of their clinic's patients received the recommended care for vascular disease. That was pretty disturbing to them. And this is in Wisconsin, Minnesota, where everybody's above average, and they were sort of below. And their answer was to actually attack this in a clinic system kind of way with this information. And so they empowered their lab technicians to check on missing tests for physician orders. They had their clinic's receptionists begin contacting patients about needed visits or screens, and encouraged their diabetes educator to follow up with the patients to ensure they were following their treatment plans and things like that. And now they moved forward 1 year later in the same Minnesota Community Measurement Report with those kinds of system interventions, pretty simple, pretty low tech, and they jumped over 20%. And the 2010 report, they were 68% of patients at their clinic were receiving optimal vascular care. And that gave them the highest score for that composite of all the 433 clinics that were in that Minnesota Community Measurement 2010 report. So they were truly above average after that. And it's just we just want to point to the power of information and what people can do with it and such. I wanted to pivot and talk a little bit about something you may have heard. I hope some of you heard about this, because we're right in the middle of Care About Your Care Month, and we had a national launch on September 15th in Washington, D.C. with Dr. Oz and our CEO, Risa Lavisa-More, and Farzad Moshari and Carolyn Clancy. But we also fanned out across the country and had activities happening all across the Aligning Forces Network and the Beacon and the Charter Value Exchange and others. The point was not that we think that one day of activity or a couple of weeks or even a month of focused consumer public campaign is going to change people's mind about what they can do with information to improve quality and help us all in this journey to improve the value of healthcare. But we really thought it was time, and a lot of us behind the scenes have been arguing for a long time about whether it was time to do a campaign like this. But given the state of the information now, it would be silly to send the public off looking for information to help make informed decisions if there's no information out there. But in a lot of settings now, there's starting to be a body of information that we can point to that people can actually use, and some other activities that they can do to be more assertive partners in this work to improve quality. And we think that the public, the consumer public, is a really important part of and driver of the ultimate solution here. So We're doing this month of campaigning and for the Improving Quality with the Care About Your Care campaign. We're going to have focus group testing and a lot of benchmark and monitoring of what happened in terms of people going to websites and things like that. And then we'll reassess after this month about how to sort of take this forward. But just wanted to put a plug in for that. So I mentioned in our early scan that we talked about payment reform, but given the state of the infrastructure and how dysfunctional everything was, and frankly the lack of payment models available for people to use, there was simply no way to integrate payment reform back in 2005 and 2006 in this kind of effort. We're sort of waiting and waiting and waiting for the opportunity, and we think the time is ripe now to do that. We all the way through, we've been asking our communities to focus on both improving the quality information that they make available to the consumers, the public, and the health professionals, but as well cost information as well. As we all know, getting cost information out of the data where it actually sits, and then finding standardized ways to measure cost and then publicly report that is still a huge, heavy haul, technically and culturally, adaptively. So, but our aligning forces communities are working on that, sort of rolling up their sleeves and running head into all of those challenges right now and attempting to do that. They are also integrating payment reform efforts into their work, and so we are helping them do that. I wanted to pause and let one of our leaders from the Puget Sound area, Susie Dade, tell her story about the challenges that they're facing as they start to move into this much stickier realm of cost measurement and payment reform. And if you could play the audio file now.
Is another person's paycheck. Performance measurement and reporting are helpful in identifying areas for improvement, but when you try to identify and reduce misuse and overuse of healthcare resources, you're starting to get into people's business model and their revenue stream. Unlike effective care for diabetes, we don't necessarily know what the right answer is when it comes to utilization of resources. In the Puget Sound area, we're beginning to measure surgery rates in areas like spinal surgeries, surgical intervention for obesity, and knee joint replacement. We are just starting to roll out these results and have a dialogue with our community, but developing the ability to measure this on a community basis is both technically and politically difficult.
Thanks, Susie. So that was Susie up in the Pacific Northwest, but we have a range of payment reform efforts that we've been investing in and prompting and whatnot over the last number of years, and that includes a $3+ million investment in the Prometheus payment model to help that team refine their model and then work on 4 pilots across the country. Those on that map appear in blue. They've also gotten funding from some of our other philanthropic partners and Colorado and other places, and so that's what you see there, in addition to the Robert Wood Johnson Foundation specifically funded Prometheus sites. All of the Aligning Forces sites are now engaging in payment reform activities, and we've had a number of payment reform focused offerings and grant offerings to promote more payment innovation across the country. And we have another one, incidentally, that's going to hit the streets, a $1.8 million offering that's going to hit the streets in a couple of weeks. So if folks are interested, they should watch for that. We don't obviously think that, and luckily that we're in this alone. This is how we're thinking, and we're doing what we can, given our role, to prompt this kind of change. Luckily, the federal government is participating in as well, and in recent years has a large toolkit of activities that are very, very helpful. So I would be remiss without talking about accountable care organizations, ACOs, and things like that. You might have gotten a sense, though, from my comments that we're fairly agnostic about the specific form that a delivery system or an improvement effort might take. Our approach has really been to help communities, marketplaces get the fundamentals right, get the information, the improvement resources, the consumer public leverage, the payment reforms right, and then let the delivery system play out. We do, however, think that this notion, this vision that's embedded in the ACO idea is very promising, particularly the idea about accountability for quality and cost and patient experience and population health. And we prepared some comments as a foundation on the CMS proposed ACO rule that embraced that and really talked about our principles of what accountability should really entail, and they're listed up on that slide. We're also very gratified that the Center for Medicare and Medicaid Innovation is offering this bundled payment opportunity that's on the streets right now. The letters of intent are due in the coming months, and so we're actively sort of prompting folks in our venues to consider that and whatnot. And again, we're not trying to take credit, but we really see this as helping sort of build off the groundwork that we helped promote over the last years to get us to a point where we could actually concretely talk about, well, bundle payments, what does that really mean, and how would you actually do that with the Prometheus investment? So that's a snapshot of kind of where we're at, and I'm going to pivot to where we're going, but this is still a where we're at kind of slide. And I mentioned aligning forces, obviously I talked a lot about that. I mentioned the Beacon community programs, which are our colleagues and our sister initiative, the Chartered Value Exchanges. So this slide is all the dots on that slide are entities that are participating in that. And there are others. There's the Network for Regional Healthcare Improvement that overlaps with that some, includes some others. The point here, there's the good news. There's a lot of activity, of regional improvement activity in local marketplaces happening across the country. That's great. There are some issues, though, because although there are a lot of bright spots, there's a lot of dark spots, too, where there isn't this activity happening. And so arguably, it does need to happen if we're all as a nation going to advance forward like we need to do, because we said we're up against it at the beginning. So there's that. There's also these three programs that are kind of related, and it's kind of a behind the stage kind of problem, but how well do they collaborate, and are they sharing, and are they getting all the learning that they're accumulating and wisdom and experience and getting it out to the rest of the country and even sharing it amongst themselves so that people don't have to keep reinventing the wheel every single time they come up to a technical problem or whatever. And frankly, we can do better. And so that's some of the things we're thinking about, working better among the initiatives, but more broadly thinking about how do you drive this kind of change across the nation, and this, there isn't going to probably be another. There definitely isn't going to be another Aligning Forces, Robert Wood Johnson Foundation, $300 million 10-year effort to do this work. So we have to find a better, faster, cheaper way to do it. And one of the things that we're doing is thinking about leveraging technology and social media, and thinking hard about networks and how to do that. That last slide, the one thing that doesn't really show up there but could is that all of those programs are based in a Washington, D.C. National Program Office, and then they're kind of spoke and hub kind of work. And this vision is much more sort of spread out across the country with vast networks of people working together in peer-to-peer ways and sharing as needed with their colleagues that are doing similar kinds of work, and really trying to prompt that kind of activity and figuring out how to do that. So that web diagram is one way to depict that. And I may have fooled you just a little bit, because that's obviously just a LinkedIn map of my personal network from about 6 months ago. And if you can imagine thousands and thousands of people's networks and the kinds of connections and the power of that, that's the kind of thinking that we're trying to promote as we sort of go to the next stage of this. More to come on all of that. There is a concrete way, though, to think about that. That seems kind of far-fetched and a little bit, what's he talking about? Well, this is one way we're talking about it. I mentioned how we're really searching for ways to use technology tools like social media to promote that kind of web improvement activity. We always have often had forums and try to prompt discussion and sharing, and they're set on our website and nobody ever talks on them, and it's really stilted and claustrophobic, and we decided just to move this discussion over to Facebook, where everybody seemed to be, and boom. This was a number of months ago. This slide is we're up to 600 people now who are all doing this kind of work, and we have spontaneous discussions and people leading their own kinds of problem solving and sharing and things like this already on Facebook right now. We don't control this in any way. We just sort of help prompt discussions and whatnot. We do participate in the discussions on Facebook, and we've done things like post concept ideas that we're going to take internally for funding discussion and ask for people to give input, and they've done that pretty assertively. I mentioned that payment reform call for proposal that's about to hit the street in a couple of weeks. We put our initial structure of ideas out there and said, please comment, give us your ideas. We want this to be better. And we got we got pages and pages and pages of great ideas as we were trying to refine our next phase of payment reform funding. So that's one way of looking at that sort of next step set of integrated integrating social media tools into networks. We do think, though, although we don't plan on having a big, heavy national program office, we do think we'll need some lighter structure, sort of a curator entity that can help the air traffic control and connect people and show them resources and highlight resources that people might need. But so it can't be completely headless. It has to have something like that. But that's kind of the way we're thinking about it. A couple of other things that are right on the top of our list are jumping in with app challenges. They're sort of mundane now, but we're trying to give ours a little bit of a gloss. I'm going to go to San Francisco on Saturday, and on Monday I'm going to announce the Aligning Forces for Quality App Challenge at Health 2.0. The Robert Wood Johnson Foundation has already conducted a couple of these challenges with our County Health Rankings program and Project Health Design. This one will be a much larger challenge with a $100,000 first prize, a $25,000 second prize, and a $5,000 third prize. And the idea is really to get developers to look at that information that the various Aligning Forces communities are posting publicly. But again, on those static websites that are kind of hard to interact with, and try to develop software applications that would bring the user into it. And my idea was sort of like in a TurboTax kind of way that sort of prompts people with questions that walks them through decision making to an informed healthcare decision rather than making them do all the work on the static website. So we'll see what we get. I mentioned Project Health Design, and that's really some of the things that are really on our cutting edge. We have been involved in this sort of broader, if you will, Health 2.0 space for a while now, and this is through our investments like Project Health Design and support for groups like Quantified Self, and that's kind of the Quantified Self bit I'm going to talk just a little bit about, but that's kind of why I was also throwing in that cycling and all the technology pieces and how important that already is to so many people and how you can imagine how that might be really helpful in health and healthcare going forward. Project Health Design is a program to spark innovation in personal health technology, and it advances, hopefully, the vision of personal health records. And right now, that project is working on how personal health technology tools can collect and integrate observations of daily living, ODLs, into personal health decision-making. And then Quantified Self is another project that we've invested in, which is, again, back to that cycling point, more and more information to help us as health and healthcare professionals understand, and people understand our health and healthcare and wellness and fitness, and really looking for those self-trackers who seek to gain self-knowledge through numbers and gaining insights in their health and health-related behaviors. I started at the very beginning saying we're up against it as a nation. With these our healthcare problems of mediocre quality and huge exploding costs, and the value problem is not really just a boutique healthcare discussion. It's front and center in our national destiny issue. But we really believe that there's a lot of hope, and I hope that's what I'm conveying here. There's a lot of people working really hard to make progress, and we're seeing progress. But all of that really depends on our ingenuity, obviously, and our technology. It doesn't always have to be the latest phaser. It can be the low-tech wristband or the low-tech approaches at the Ellsworth Clinic. But it can, and sorry to mix sci-fi TV and movies here, but it is really important, and we are making progress, and we're very hopeful. So with that, I'll end, and maybe we have some time for some questions. Thank you.